Hello, fellow leaders. My name is Brennan Wynn, and our group is here today to propose an improvement process on hand hygienes in order to reduce the spread of germs and infection. With that said, according to the CDC, each year millions of people acquire infection while receiving care or treatment in a healthcare organization. Healthcare associated infection is the biggest issue that's affecting many patients today. On average, healthcare providers clean their hand less than half the time as they should. As a result, one out of every 25 hospital patients has at least one healthcare associated infection. Thus, the best way to reduce the HAI is by improving hand hygiene process for healthcare staff. According to the Joint Commission 2016 National Patient Safety Goal, NPSG 07-01-01 aims to reduce nosocomial infections by emphasizing hand hygiene. Thus, it mandates healthcare organizations to comply to the reduce of spread of germs and infection by providing staff with a proper hand washing technique, installing hand sanitizer throughout the hospital where patient care occur, and lastly to post hand washing protocol to serve as a reminder for staff. However, we would like to improve the process by implementing timers on a sink, similar to the one they are installed in a scrub sink, to monitor staff and compliance with CDC recommended time of hand washing practice. In other words, it serves as the timer would serve as a robust surveillance system where infection control team can monitor staff as how long they are taking the time to properly washing their hand. Thus, from these valuable data that they collect, they could facilitate a metric and develop framework for staff training. With no further ado, I would like to turn over to my colleague, Aaron, who will address the area of plans and do. Thank you.
The API improvement model asks three major questions. Where do we want to go? How will we know if we've arrived? And how are we going to get there? Basically, it establishes goals and helps the team to refine their initial strategy. Our team has a specific goal: to reduce hospital-acquired infections by improving hand hygiene, compliance, and quality. We'll measure these things with audits, which can monitor personnel and track equipment use in key hand hygiene zones. This data could be compared to infection control rates in similar zones. Our changes will include implementing 20-second sync timers, performing staff audits to measure compliance, and distributing educational programming. The focus model, developed by the Quality Resource Group and Dr. Paul Batalden, explores the opportunity, team, process, variation, and strategy surrounding an issue. Focus can be used to generate information about undesired variation, which can subsequently be implemented into the PDSA strategy. Essentially, it lets us take a baseline prior to engaging with the change process. First, for F, we look at what our organizational goals are. What do we want to achieve? In our case, we found an opportunity to improve hand hygiene compliance and, as a result, decrease hospital-acquired infections. Next, for O, we put together a team or committee to work on the improvement. Our guiding team would be composed of staff from multiple disciplines, all following our plan. Then, for C, we use flowcharts to clarify how the process works currently. For U, we'll use Ishikawa fishbone diagrams to identify problems, variations, and obstacles in the current process. Finally, for S, we'll initiate the PDSA cycle. The PDSA methodology will be used to generate our strategy. In the first stage, we'll review data, establish objectives, identify targets, and create a strategy. In the second stage, we'll implement the strategy on a small scale. In the next stage, we'll look at our results and compare them to our target or goal. Finally, in the last stage, we'll determine if we need to create a standard or restart the PDSA cycle. In the planning stage, it is critical that the guiding team selects objectives. For example, our organization might focus on the importance of hand washing over hand gel use as a means of reducing C. difficile hospital-acquired infections. We might say that we hope to see a certain 5% reduction in annual infections for all ICU floors. Part of our plan involves reviewing data that identifies the current process. The flowchart diagram shows us the process as it currently is. Notice that in red, some trails lead to poor outcomes. The flowchart allows us to see areas where we can improve upon a process. Education and tool access appear to be some of the highest risk areas that are identified by the flowchart. The Ishikawa diagram, drafted during the focus process, helps the guiding team plan the quality improvement initiative. The team can identify problems that led to undesired variation, such as poor hand hygiene. Data for the diagram is compiled from staff interviews and is sorted into subgroups. The quality improvement team or committee should analyze the data and address concerns when formulating the plan. For example, many of the staff members mentioned conflicting information, inadequate training, and a lack of standardized protocols. This feedback suggests that educational materials and training should be included within our plan. After reviewing the data and establishing objectives, we can formulate our strategy. First, the organization will address equipment issues within the system. This includes installing timers on all hand washing areas that will ensure that the water remains on for at least 20 seconds. Secondly, an educational program will be rolled out that will clear up misconceptions about hand hygiene and help staff make the connection to hospital-acquired infections. Lastly, audits will be performed to ensure compliance. This will include audits on equipment data and visual observations of personnel.
The first strategy we will use as we implement our fix is installing timers on all the sinks in the facility. These timers are hands-free and once activated ensure that the water remains on for at least 20 seconds. The purpose here is for employees and patients to be mindful of how long it takes them to properly wash their hands and get rid of germs. We are placing signs above the sinks to explain to employees and patients why the timers are there and how they work. We are also installing automatic paper towel dispensers and making the sinks turn on automatically to further inhibit the spread of germs. One problem we are discovering is that the timers can be a pain when you want to use the sink for other purposes and the water stays on for too long, becoming wasteful. Another problem is that the 20 seconds is sometimes not enough time, which could lead some patients or employees to believe that their hands are clean when in fact they are not. The second strategy we will use to implement our fix is to incite urgency among staff members and patients through implementing an educational program. This program will include all sorts of information that will help employees and patients alike understand the importance of hand washing and debunk some of the common misconceptions. Additionally, this program is intended to help personnel see how hand washing relates to decreasing the number of HAIs. Information will be posted on bulletins around the facility as well as in bathrooms. For example, we will post eye-catching signs in the bathrooms that will have a picture of which areas of the hands are commonly missed that carry a lot of germs, for example, under the nails. And we will include information about why it is important to take time in washing your hands. Signs will be in multiple languages due to the high number of international patients in our area. The third and final strategy we are using is to perform audits on personnel and equipment in order to ensure compliance. The equipment will be checked on a weekly basis to make sure it is working properly. Employees will be monitored visually to ensure compliance with the hand washing initiative. However, there is a problem we are encountering with this. We are having some difficulty monitoring employee compliance due to the private nature of most hand washing stations.
To measure the results of our implemented fix number 1 of installing 20-second timers on all sinks, data for infection rates will be collected and then analyzed. This analysis will determine if the infection rates within the procedure areas that house these hand washing timers are helping to keep infection rates low. If infection rates are instead increasing, then further investigation needs to be completed to see if this is a direct result of hand washing or other factors. The second measure will be to use anonymous employee surveys to judge compliance rates for hand washing techniques. Education is the second implement fix within our strategy. Eye-catching educational posters will be displayed throughout the hospital to show the process of hand washing and support the importance of it. These posters will give hand washing steps and reiterate the importance of good technique. Secondly, at new employee orientation, employees will be required to attend a hand washing class that will teach the proper way to wash hands and why this is also important. Thirdly, each year employees will be required to complete re-education for hand washing techniques and the importance of completing the process correctly through computer-based technology. Finally, with implement fix number 3, infection control data will be analyzed to rule out hand washing as a reason for infection. Visual monitoring will be completed on a peer level and an administrative level to ensure compliance. Anonymous employee surveys filled out to give feedback whether the hand washing implementation is seen as a positive step, which these surveys could also be used as compliance guidance surveys. There have been other organizations that have had success with hand washing strategies. The World Health Organization Hand Hygiene Program is the first I will touch on. The countries that took place in this study were Costa Rica, Italy, Mali, Pakistan, and Saudi Arabia. There were 5 primary concepts within this study. These were, number 1, access to alcohol-based hand wash at point of patient care. Number 2, healthcare worker training and education. Number 3, monitoring of practices and provisions of feedback regarding performance. Number 4, visual workplace reminders. Number 5, establishing a safety climate within the institution. Each site then implemented the 5 primary concepts within a 4-phase system. Each system then lasted 3 to 6 months. These consisted of preparedness, baseline, assessment intervention, and follow-up assessment. The primary outcome was compliance, which was assessed by direct observation. The secondary outcome was healthcare worker knowledge about microbial transmission of healthcare and hand hygiene best practices. This was assessed by questionnaire. At the end of this study, compliance increased from 51% to 67.2%. After 2 years, all sites reported continued hand hygiene activities or further improvement. The second study that I was going to talk about is a 2008 Cochrane study, which was completed in long-term care settings. This included the introduction of new hand hygiene products, implementation of infection control practices and policies, surveys, and electronic monitoring. The before and after studies were reviewed, and 58% reported a significant re-education in healthcare-associated infections within the interventional group compared with the control group. So the last study that I'm going to talk about was done in Europe. This is where 41 studies were reviewed by an independent agency between 2000 and 2009. These studies were based primarily on either knowledge, awareness, action control, or facilitation of behavior. There were a few studies, however, that were based on social influence, attitude, self-efficacy, and intention. Within this study, it was found that 13 used a control design to measure the effects of hand hygiene improvement strategies on hand hygiene behavior. There were positive results within the control study that found when using one determinant gave a 17.6 compliance rate of hand hygiene, but when using a combination of determinants, there was a 49.5% compliance rate on hand hygiene behavior. It was also found that addressing factors such as social influence, attitude, self-efficacy, and intention showed better results within the study than addressing such factors as knowledge, awareness, action control, and facilitation alone. So basically a combination of the self-efficacy, attitude, social influence gives a better result on the hand hygiene behavior than when just using the others singly. So overall, the study states they believe that there could actually be a 15 to 30% infection control rate with adequate hand hygiene practices if they were observed.
We are achieving Level 3 and Level 4 mistake proofing with this initiative. Level 4, or self-inspection, occurs when the timers remind employees and patients to wash their hands for longer to reduce bacteria and viruses as they are washing their hands. Level 3, or work unit inspection, occurs when employees are audited to ensure insufficient hand washing defects are not allowed to continue. Our data reflects a 15% lower incidence of HAIs in the areas where the timers were installed. Now, this may not sound like a lot, but it is enough to show that washing your hands really does lower the chance of spreading disease. This number is made even more significant when we look at the surveys of employee compliance. Employees only complied with the hand washing initiative at a rate of 45%, which means that more than half of the employees were not complying. Can you imagine how much more lower the HAIs would go if employee compliance was increased? We can learn a couple lessons from this. First, employees are not feeling the need to comply, and second, the fixes are working, but compliance needs to be higher for them to work better. So what next? We need to show employees the positive results we have had with reducing HAIs from hand washing and encourage them to comply. Additionally, since our results weren't totally mistake-proofed, we need to consider re-entering the PDSA cycle.